Hello, good morning, everyone. My name is Deontay Marquis. I am a family nurse practitioner, and today we will be discussing wound care prevention and management. Now, this presentation is specifically for the registered nurse. If you are not a registered nurse, there is another presentation for non-licensed registered nurses. If you also want to know and learn more about wound care prevention and management. But this presentation is specifically for the registered nurse interested in learning about wound care prevention and management. And this is presented to you on behalf of my ALF Training. So let's go ahead on and begin our presentation for today. So today, as you can see, we will be talking about wound care prevention and management. And we have just a few objectives, but there's a lot of material that we're going to be covering today. So just sit back. It's going to be an hour. We're going to learn a lot. I'm going to ask you guys some questions. And we're going to have a great time learning about wound care prevention. So our course objectives for today are identifying the role of the registered nurse in wound care. So specifically, if you are interested in uh, learning more about what your role is as a registered nurse in wound care, we're going to delve deep into that topic today. Additionally, another course objective, we're going to identify the major pressure points that are on the body that are most susceptible to having some type of wound, whether it be a pressure sore, an ulcer, or different types of skin tears. We're going to really zone in on where on the body we should be checking for these wounds so we can know how to safeguard and prevent against them. And lastly, our third course objective will be identifying different wound types and basic assessment findings. So things that we'll find that'll let us know what one wound is in comparison to another type of wound, so that when we see these small characteristics and subtle traits, we know exactly what we're looking at, and therefore we know exactly how we should be treating it to heal or prevent the wound if it's still in the early stages. So, first, of course, we want to know, what are my responsibilities? Well, our responsibilities as a registered nurse, as you'll see in the right hand side there, all aspects of wound care. You've probably heard this phrase before, but nurses are the last defense against everything that can happen to the patient. It's our job. We're the last line of defense. We're the goalie. If you pay attention to soccer, we are making sure that nothing gets through. So when it comes to wound care, this is no different. Um, so we're responsible for all aspects of care. But specifically, if you're wondering, Deontay, well, what do I do to prevent wounds, or how can I really step into my role and take more action to prevent wounds? Well, the first thing we can do is assessing the wound or the area where there is perceived to be a wound, and document what we see. When should we be doing these assessments? Well, we should be doing these thorough assessments of the skin, of the integumentary system, completely whenever we admit a new patient, whenever we discharge a patient, and every single shift. We should be doing these very detailed, thorough scans of the skin, noting any areas in question, even if there isn't a wound. If this area of skin just looks a little bit weaker than the rest, we need to document that, because what that's going to do is it's going to alert the rest of the medical team um, that, hey, this nurse noticed something in this area of the skin. So we're going to make sure that we take some extra action there to make sure that this skin, even though there was no breakdown, there was no questions to the integrity of the skin, but it felt a little weaker, or it looked a little bit drier than the rest, or it looked a little bit more red, or it was a little bit warmer, or a little bit cooler than the rest of the skin. We're going to take note of that. We're going to take action on those findings. So it's very important that we assess the wound completely and document the findings. And like I said, not just the wound, but the entire area of the skin. Also, what we should be doing is applying preventative techniques. Now, when I say preventative techniques, it sounds more fancy than it is. So don't be fooled by the word techniques. It's just different practices that I'm sure you are already implementing in your care of your patients. Um, but these techniques include things like turning the patient every 2 hours, or offloading areas of the body which uh, have constant pressure, offloading that pressure so that that constant pressure uh, isn't continuously exerting on the body. So basically, it's intermittent. So now we give the body a chance to recover. For example, if the patient's sitting down on their butt, we want to stand them up and walk them around. We don't want to let them sit in the bed all day. So uh, those are just different techniques that we can use to reduce pressure and also allow a wound to heal if there is a wound in the area. And lastly, what we can be doing, and I've found in my practice as a nurse, that wound debridement, a lot of nurses wait for a uh, specific wound care nurse to do wound debridements or wound cleaning, um, or sometimes even dressing changes. So I want you to know that this is also our responsibility. This is the clinical nurse's responsibility, not just the wound care nurse. The wound care nurse is there to really get technical, and if we are unsure about how to do certain type of wound debridement or dressing changes, we can ask them. They're also there to make more detailed recommendations of what we should be using, how we should be using it, and when. But still, as you can see in that right-hand corner, this right side of the presentation here, we are responsible for all aspects of wound care. It's our responsibility, guys. So, um, I've talked to you about what a thorough assessment, well, not a thorough assessment, but I've talked to you that a thorough assessment is one of the first things we can do to really step into our role as nurses. But what does a thorough assessment entail? Well, the first thing we should be doing in a thorough assessment of the skin, when looking for wounds or signs that a wound may be presenting, is we should be noting the anatomic location of the body. So this is a very important information. We need to know where the insult to the integrity of the skin is occurring. Is it on the right heel? Is it anterior? Is it posterior? Where on the body? So we need to be specific, and we need to be exact so that the nurse knows exactly where the insult is. Because when they come behind us, or another member of the medical team comes behind us, we don't want them guessing. We want them to go exactly where we went on the patient's body, and we want them to see exactly what it is we saw. So, the first thing in a thorough assessment should be the anatomic location, the where. Second, we should be identifying the stage or the degree of the wound, because this helps us in determining the healing trajectory of the wound, and this can help guide our care plan. We also want to ask, is it partial or full thickness? Is it stage one, stage two, three, or four? So we need to familiarize ourselves with what these terms mean, what separates a stage one from a stage two, so that when we see this wound in our assessment, because we're trying to be better nurses, um, and step into our role on the wound as a wound care in wound care for our patient, we need to be able to identify the difference between these wounds. So that is what we're going to get to today as well. So at the end of this presentation, you guys will know exactly what separates a stage 1 from a 2, from a 3, and so forth. So when you're doing your assessment, you will know and you will document everything appropriately. So last but not least, the third key component to a thorough assessment when assessing the skin is noting the wound size. So if we do see a wound, we want to make sure we measure it, not an approximate measurement, not taking our finger or some other device and putting it next to the wound and estimating the size. We want to know exact, because that's going to let us know if our efforts uh, have been working in decreasing the size of the wound, or if something else is going on. And despite our efforts to offload pressure and turn the patient and applying different creams or dressings to the wound, if none of that's working, then something else is going on and we need to step it up. So knowing the wound gives us some type of concrete evidence so we can measure and chart our progress in healing this wound. Or knowing if it's getting worse so we can step up our treatment. So when you're measuring a wound, you want to use the head to toe axis. So you want to go from top to bottom. And width, of course, is side to side. If the wound has a depth, so depth meaning it's probably stage 2, 3, or 4. So if it's tunneling through some type of depth, appears like a crater, then we want to make sure we take a sterile cotton tip applicator and we insert that into the wound gently to the deepest point of the wound, and measure from there to the surface. So what I do is I insert the cotton tip applicator into the wound, and I'll maybe take a piece of tape and at the top. So if this is my cotton tip applicator and this is the wound here, I'm going to put this in and put a piece of tape around this edge here. And then when I take the cotton tip applicator out, then I will measure and see the exact depth of the wound. And a key point to remember, you always want to go to the deepest part of the wound to get the most accurate measurement. You don't go to the shallowest or the middle. And yes, sometimes this is painful for the patient, but it is in their best interest. Now you'll see here at the bottom, I have surrounding skin. Now surrounding skin, I didn't want to include this as one of the key components of a thorough assessment, but this is, again, very important. We want to note the surrounding skin, what it looks like. Is it also starting to show signs? Is it red, reddened, warm, showing signs of infection? Because the surrounding skin can also tell us a lot about the wound. But for the purposes of this presentation, I really want you guys to focus on those 3 key points, basic of assessment, the basics of a thorough assessment that we talked about. So I included this excerpt here from the Journal of Advances in Wound Care. So I want you to take a minute and read this, and you'll see I have in red some very important information that I will talk to you about in a moment. Okay, so you had a moment to read through. So basically, I included this excerpt from the Journal of Advances in Wound Care. It was published in 2018. And what it's basically, the meat of this excerpt is, it's telling us what patient group and what areas of the patient's body are seeming to be most susceptible to wounds. So in red, the spinal cord injury patient population is the highest risk of developing a pressure ulcer. Why? Well, because this group is prone to a lot of pain. Spinal cord patients and injuries, they go through a lot of pain. These are very painful back surgeries, most likely numerous surgeries. Um, so they're not moving around a lot. They don't want to move around because it hurts. So, of course, they are very susceptible to developing a pressure ulcer. Now, nursing home patients also have a high pressure ulcer prevalence, and they are most likely to develop ulcers over the sacrum or the heels. So, if you're working in a hospital and you encounter a patient who's had some type of spinal cord injury or has a history of a spinal cord injury, then there's a very high chance that that patient will develop uh, some type of pressure ulcer while they're staying in the hospital. So you want to make sure that you really rev up your efforts if you encounter this type of patient. Now, on the other hand, if you're working in a nursing home, you want to make sure that you're paying special attention to the patient's heels and their sacrum, because these are high prevalence areas where the patient can develop uh, a wound if they're a nursing home patient. So, if you remember, just 2 slides ago, we talked about location as one of the key components of a thorough assessment of the skin. So, um, let's note all the red areas on this patient. So, here, the pelvic area, the knees, the fronts of the toes, the ears, the shoulders, the side of the pelvis, the lateral knee, lateral ankle, down the spine, all these areas in the spine. So we can see why those patients with spinal cord injuries have a very high prevalence of developing a pressure ulcer. And also when sitting. So note the position, standing, sitting. The most common areas are the shoulder blades, the buttocks, and the sacrum, the lowest point of the back here. Those are the most common areas, the shoulder blades, the buttocks, the soft tissue in the buttocks, or the sacrum. So we want to make sure that when we are looking at those areas specifically, and if you notice, the majority of those areas on the last slide, and even here, are areas of the skin which cover a bony prominence. So those are high pressure areas, areas of the body that have bony prominences, which come in contact with flat surfaces for prolonged periods of time. So what area of the body is in touch with a flat surface for the longest amount of time? Well, you and I are both probably sitting, so our butt, that's what's in touch with a flat surface. And next, our back and shoulders, if we're sitting all the way back in a chair. So those areas, as you saw on the last slide, are the most likely. Now, in our elderly patients, it's the heels. So why is that? Well, I would postulate because elderly patients tend to have other comorbidities that also increase the likelihood that they'll have edema. And so that additional swelling on the legs probably places them at a higher risk to have pressure sores or some type of skin breakdown on the heel. But nonetheless, high pressure areas, bony prominences, that's our location. That's where we're looking. Now, we're not just looking there because there are also other areas of the body which can also be very prone to pressure related ulcers. And those are areas that are in constant contact with a medical device. Specifically, the most common would be a nasal cannula or a Foley catheter. So, if your patient has a nasal cannula, is on continuous oxygen, or has a Foley catheter, then we want to make sure that we are paying special attention not just to the bony prominences, but also the soft tissue areas where these medical devices are in constant contact. Because we want to make sure that we're offloading the pressure, we're reducing the friction caused by these medical devices with either some type of cotton swab or a gauze or some other uh, soft cloth fabric to keep that medical device off the soft tissue and causing these pressure sores here that we see. Okay, so Uh, Location for our assessment, we're looking at bony prominences, and we're also looking for areas of the body in touch with medical devices constantly. So we've already covered anatomic location, where we're looking for the wound. So next, we're going to talk about the stage of the wound, whether it's stage one, two, three, or four. And remember, this is going to help us with our assessment to fulfill our role as a nurse when we're handling a patient with a wound or at a high risk to develop a wound. So we want to know the anatomic location. We talked about that. And now we're going to get more in depth about our different stages of a wound. And I also left this here because, as I said before, part four, or just the asterisk, not a key component of a thorough assessment, but I definitely want to include it here, is the peri wound, the surrounding skin. Um, it can tell us about the presence of an infection. It can tell us how painful the area or the wound might be. And even some nurses can tell how long the wound has been present just based on the peri-wound area. But first, let's talk more about the wound types. Uh, Three specific types we're going to talk about today: arterial versus venous ulcers, skin tears, and pressure sores, stages 1 through 4. So, venous ulcers, as you see, I have this picture here. Very common. I've seen these multiple times throughout my practice as a nurse, and I'm sure you may have encountered them a few times as well. Venous ulcers occur in 80 to 90% of leg ulcers. So, if the patient has some type of leg ulcer, most of the time it's going to be a venous ulcer. Now, that's important to note just because of the etiology of what causes a venous ulcer. So, if we can identify the what caused it, or we can identify a venous ulcer by the location. So the location of a venous ulcer is usually the inner and or medial lower leg. So if you see the medial here of this patient's leg, the inner and also the outer, they've got this irregular, very large but shallow kind of skin breakdown on the legs. So that's the size and the shape, and it's you see it's reddened in this area, discolored here and here, and kind of granular. Uh, that's very key characteristic of a venous ulcer. What causes this? It's caused by venous insufficiency. Um, there's a flow problem causing fluid retention that's creating constant pressure on the skin that causes this breakdown, that causes these veins to burst, and it ends in this ulceration here that we see on the legs. So venous ulcers. Now, in comparison, arterial ulcers. Now, arterial ulcers, they are have a different location, size, shape, and etiology than venous ulcers. So arterial ulcers are located more so on the foot, not the leg. They're located on the foot, specifically bony prominences in the foot. So you'll see here where this is right on that bone on the foot, the frontal, I believe that's called the malleus. I'm not sure. Um, Anyway, so they can present there in between the toes, on the heels, and they have more of a punched out um, appearance. That's why I included this fist here. So when you think of arterial, think of punched out, um, because they have a rounded shape and the edges are more defined. So it's almost as though someone just put their fist right through the wall and then take that picture and put it on someone's foot, and you have an arterial ulcer. That's what it looks like. Um, the color is going to be yellow or brown mostly, but sometimes it can even be black. Of course, that's an indication that it's been there a while and the tissue and skin around it is dying. It's becoming necrotic. And this is, again, caused by peripheral vascular disease, but from blocked arteries. Then the arteries aren't able to pump blood and oxygen and nutrients to a specific area. It may have rubbed up against the patient's shoe or what have you, causing a small insult to the integrity of the skin in the area, which then, without the proper oxygen, blood, and nutrients, it started to die out and cause an ulcer. Now, unlike the venous ulcer, arterial ulcers are much less frequent and occur in less than 10% of all leg ulcers. So we talked about the difference between arterial and venous. So now we're going to talk about the stages of a wound. As you can see here, and you may have already guessed, this is a stage one. In a stage one pressure sore, the epidermis isn't broken, but as you can see, it's very red, sometimes discolored in darker skin tone patients when comparing to the surrounding skin. Um, if the patient has a darker skin tone and you're unable to note any differences in the color, then use your hands and feel for changes in the hardness, softness, or temperature of the area compared to others. This area that is on the patient in a stage one, it does not blanch. Blanching is when we press the reddened area of the skin and it does not turn to white, indicating that the blood is already pooled at the surface of the wound. Whereas if you press your skin and let go, you'll see that the skin where your finger was turns white and then fills back with blood, and the white goes away. So that's called blanching. In stage one, there is no blanching. Just a quick review, talk about the skin. So in stage one, the epidermis, that would be this layer here, is red. Just the epidermis, this top layer. So stage two, the epidermis is broken. The dermis may also be broken. So we can see here, this outline lets us know that the skin is broken and we can see it's bright red beneath. So don't be confused that this is bright red and there was a bright red in stage one, but in stage two, the first layer, the epidermis of the skin, is broken. There might also be, the dermis may also be broken and damage may be present to the subcutaneous layer beneath, but the wound doesn't tunnel through. It looks like a shallow sore, a shallow open sore, or a popped blister. And if it doesn't look like a pop blister, sometimes this skin may still be holding on, but you can see that underneath it, the first layer is broken. And there may or may not be some drainage or pus. So you'll see here again, the epidermis is red in stage one, but in stage two, the epidermis is broken. And then as we saw, this area is very red beneath it, the subcutaneous layer right here, going down into here. Now, stage three, the wound extends through the epidermis and the dermis and exposes the subcutaneous layer. That fat may be visible, but the bone, tendon, and muscle are not. And the wound may appear as a small crater. So see here, the first layer is broken, the second layer is broken, and we can see the subcutaneous, this white matter here. But no bone, we can't see bone, we can't see tendon, and it definitely looks like a small crater. Definitely looks like a small crater. So we extended through the epidermis to here. We also extended through the dermis and exposed the subcutaneous, which was the white matter we hear. So we exposed it because the wound came through this layer all the way down to here and exposing, so we can see a little bit of the subcutaneous fat. Now stage four, the last one. The wound extends through the epidermis, the dermis, all the way through the subcutaneous layer, and it can even go down as far as the bone. And there's usually a lot of dead tissue and drainage. So I'm not sure what that is. I call that drainage. You can see all this tissue around is dead, bright pink, the subcutaneous layer there. And it's not the best picture to see muscle or bone, but you can tell the difference between a stage 3 and a stage 4. And there's a lot of dead tissue and drainage are present. Now put these side by side. Please excuse this extra text here. Let me get rid of that. So just so you can see a side by side of the wound progression. So stage 1, it's just a reddened area, but the epidermis isn't broken. Stage 2, the epidermis is indeed broken. May or may not proceed through the dermis, which would be this wavy line here. Stage 3, it has broken through the epidermis, the dermis, and exposing the subcutaneous layer, and it appears as a crater. You see how they use this illustration to show that there is indeed a crater. And stage 4, this is just complete destruction of epidermis, dermis, subcutaneous layer. And this is the bone here that's now been exposed. So we've gone through the anatomic location. We've gone through our different types of the wounds. So we've talked about arterial versus venous. We've talked about stage 1, 2, 3, and 4. And I also just want to mention that a skin tear, as some of you may know, some of you may be confused, but a skin tear is not considered a stage 1 pressure sore or an arterial ulcer. A skin tear is a completely different entity by itself. It's usually when the skin is dry, the patient rubs up against something, or when turning the patient with a sheet, it digs into their skin, or for whatever reason, just creates a cut where the skin flap is either still attached or unattached, very shallow, and that is what we consider a skin tear. Um, so don't get that confused with a stage 1 pressure sore. All right. So now we're going to talk about measuring the wound. This, as you remember, was the third most important thing when we are conducting our assessment uh, of the skin. So as I demonstrated, but now I have a picture here, the Q-tip should be inserted into the wound to the deepest part. And I said I usually put a piece of tape here, or you can just grab it with your finger and then measure to get an accurate depth of the wound. And then also you want to measure the width, but of course you don't need your Q-tip for that. You can just put the tape, measuring tape from here to here and measure. And this is important because it's going to help us track our progress when we're trying to gauge the effectiveness of the treatment we are giving to the wound, to the patient to help heal it, or if the wound is already healing, or if there isn't a wound present and we just see a reddened area, perhaps it's just a stage 1. So what you want to do is you want to measure the width of that stage 1, and you want to make sure that every day as we're coming back, the width of that stage 1, the redness is getting less red, the width is getting smaller. So we know that what we're doing is working, and this isn't getting worse because we don't want to have a stage 1, and we definitely don't want a stage 1 to transform into a stage 2, especially in the elderly population in the nursing home, because it is very difficult to manage wounds in these patients because we want to give them some type of independence. But when they have a wound, we have to take that independence back. And as you may or may not know, that is sometimes a bit of a struggle. So we want to make sure that we're doing what we can to prevent. And how can we prevent? Through assessment, documenting, and applying preventative techniques. So what do we do to prevent? I'm glad you asked. Well, wound care and prevention, specifically offloading pressure. You may remember I brought that up earlier in this presentation. Well, here we are again. So, offloading pressure is just relieving pressure on vulnerable areas of the body. And we talked about the vulnerable areas of the body, the locations that we should be looking out for, which are more likely to develop pressure sore. And those were our bony prominences and the areas of the body that come into contact with medical devices for prolonged periods of time. So, what should we be doing? I call them techniques, but it's simple practices. We should be repositioning the patient every 2 hours, noting where they were, and uh, rotating them the opposite way of where they were, just to distribute the pressure evenly on the body and break up that persistent, constant pressure of them sitting on one side of the butt or laying on their back. So we want to make sure we're doing that. Also, using pillows. So, as you see here, this is a perfect example of how to offload pressure on a patient's heel. And we talked about how the heel and the sacrum were two of the most common areas for patients in the nursing home to develop a pressure sore. And last but not least, we want to keep the head of the bed less than 30 degrees. What this is going to do is decrease the amount of pressure that's on the sacrum and even on the back by keeping the head less than 30 degrees on these patients, except during meals. It's okay to set them up for meals. And also, another method would be to reduce friction and shear. We want to keep the bed free from crumbs and particles because these can irritate the skin. So, yes, it's okay to let the patient eat in the bed, but we need to use a towel or something to catch the crumbs and particles. Make sure we're changing the sheets before bed if they did eat in the bed, or there could be some type of crumbs or particles in the bed that would irritate their skin. Um, just the little things we want to make sure that we are catching because we don't want them to grow into big things. Also, we want to avoid dragging the patient over the sheets. It's okay to use a pull sheet, um, but we want to make sure that we bend the patient's knees before moving them. We don't want to pull them with the full pressure and weight of their body on their butt or on their coccyx. So we can avoid this by bending their knees. Also, as needed, ask your management about offloading boots. Ask them about more pillows. Ask them about elbow pads. If you do the assessment and you see an area of concern, and again, we want to catch it before it's a stage one. We want to note it just when the temperature in that area seems a little bit warmer than the rest, or a little bit cooler than the rest, or a little bit drier than the rest, or the patient's complaining of pain to that area for whatever reason or soreness. That's when we want to catch it. So if you note one of those findings that let you know, hey, something might be wrong. I don't want this patient to develop a pressure sore. I'm going to ask my management for an elbow pad and have this patient wear it for the next 3 days until this elbow um, gets back into normal, until I feel comfortable that this elbow can will be okay by itself. So that's what we want to do. Also, key points in wound care prevention: moisturize the dry areas and dry the moist areas. I'm gonna say that again. We want to make sure that we moisturize the dry areas and we dry the moist areas. So if the skin is dry, we're applying some type of lotion or conditioning cream to the skin. And if the patient just had a shower, just had an incontinent episode, we want to make sure that we're drying the moist areas. And if the patient is obese or for whatever reason has skin folds anywhere, we're putting powder in between them because they may sweat, they may spill something on their shirt, and if that liquid or sweat stays in between the folds for too long, then it could cause breakdown of the skin, bacteria. So we want to make sure that we're cleaning and putting powder in between the folds. Let's see where we're at here. Okay. Uh, Wound care and prevention still. So we want to make sure that we're properly hydrating and giving proper nutrition to our patient, because nutrition and hydration actually prevent skin breakdown and promote skin healing. So nutrition is not something we should overlook. I know as nurses, we have a lot going on: medications, family, doctors, um, wound care, but nutrition. We want to make sure that we are encouraging our patient to eat. They are getting a well balanced diet, and that someone is with them making sure and documenting their intake. Um, we want them to have a very protein rich diet. So, red meat, shellfish, beans, yogurt, nuts, cheese, things like that, unless specified otherwise by the doctor. And as far as hydration, we want to make sure we're encouraging the patient to drink fluids, uh, hopefully eight, eight, uh, 8 ounce glasses, so 64 ounces of water, unless otherwise noted by the doctor, as if they have some type of kidney disorder where too much water is not good, or some type of uh, heart failure where too much water would not be the best, because dehydration can actually thin the skin and elasticity. So if they're not hydrating well, their skin is thin, it's not very elastic, and it's dry. That's a prime opportunity for a skin tear to develop, and a skin tear can then turn into uh, stage two to a stage three pressure sore, depending on how it's handled, depending on where it is. So we want to make sure nutrition and hydration, very important in our nursing repertoire of defense against wounds. And last but not least, we want to make sure that we're developing and executing a plan. That is why I feel that assessment is so important in wound care and management, because it'll ultimately guide us in developing a plan that's specific for our patient. Um, and that we're collaborating between all medical disciplines. So we need to talk to the doctor. We need to talk to the wound care nurse. We need to talk to the dietitian. We need to collaborate with all of them to come up with a successful, effective plan, and we need to execute it accordingly. We need to also include the CNA, because we want to make sure that our patient's being turned. Even when we're not available, we want to make sure that everything is being done to prevent this wound or to manage this wound into something that will not cause a serious issue for the patient. And why is this presentation important? Why are we spending so much time talking about wound care? Um, these patients are already sick. They're going to be susceptible to a wound, and that may be true, but it does not have to be a part of their medical list of health disorders. This is something that we can prevent. Pressure ulcers are some of the most common health conditions in the U.S. and affect more than 2.5 million individuals annually. It affects the quality of life, the quality of care. It can disrupt the sleep pattern. It makes the patient more susceptible to infection. So this is something we definitely want to take care of. We want to manage this issue quickly, and more importantly, we want to uh, put the extra effort forward in our assessment to prevent any type of wound from occurring. And that's it. That concludes our presentation. I told you it was going to be a lot of information, but hopefully you were able to understand how important this is and understand the importance specifically of the assessment, thorough assessment of the patient's integumentary system. You were able to understand the difference between stage one, two, three, four, arterial ulcer, venous ulcer, and a skin tear, so that when you go into the patient's room and you see some type of insult to the integrity of their skin, You can not only assess it thoroughly, but document correctly what it is when we stage the wound and pass that information on to the rest of the medical team and the nurse so we can work together to track the progress of this wound and make sure that it heals appropriately. So now we are going to get into review questions. So I'm gonna let you read this question and then I'm gonna read it with you and give you a moment to answer the question. So during handoff, the nurse tells you a newly admitted patient has a history of severe peripheral vascular disease, and she noticed some scratches on the lower legs, but was unable to complete her full skin assessment. This patient likely has which of the following? So, in this question, the nurse tells you that a newly admitted patient has a history of severe peripheral vascular disease, and she noticed what appeared to be scratches on the lower legs of the patient, but she didn't complete her full skin assessment for whatever reason. So, which of the following wounds does this patient most likely have? Is it a stage 3 pressure ulcer? Is it B, a stage 4 pressure ulcer? Is it C, an arterial ulcer? Or is it D, a venous ulcer? Give you a moment to answer this question. The answer is C, arterial ulcer. So let's go back to the slide there. Oh, wait a minute, guys. So it is venous ulcer. I'm sorry, venous ulcer, because we talked about she saw what appeared to be scratches on the lower legs. And we talked about how venous ulcers present on the legs as opposed to arterial ulcers present on the foot. And this patient had very bad peripheral vascular disease, this venous insufficiency. So venous ulcers appear on the legs. So that was the key indicator in that question there. It may have been a little tricky, but venous ulcers, I just want to make sure you guys are understanding the difference between a venous ulcer and an arterial ulcer. So let's get back to our questions. So correct answer is not arterial ulcer. The correct answer is a venous ulcer. There we go. All right. So next here, question number 2. Which of the following bony prominences are patients in a nursing home most likely to develop a pressure ulcer? So if a patient is in a nursing home, which of the following bony prominences is the patient most likely to develop a pressure ulcer? Now, we talked about this, and we also read from the excerpt of the journal which areas of the body and even which patient population are most susceptible to pressure ulcers. So, which area? I give you guys a moment. There were 2, but this is a choose one question. All right, let's see if you got the question right. So the correct answer to this question is the heels of the foot. So let's go back to the journal article here. Here we are. Nursing home patients have a pressure ulcer prevalence of 11%. So 1 out of 10, and are most likely to develop pressure ulcers over the sacrum or heels. We want to remember that. So if you're working in a nursing home, the sacrum or the heel. So if your patient has some redness, a reddened area over the sacrum, we want to make sure that we're implementing those preventative techniques. And if the patient has redness over the heel, we want to make sure that we're offloading the heel. So we want to make sure that we're floating the heel over the edge of the bed by propping it up on some pillows, just as we saw in this picture here on this slide. So what they did is they propped this foot up, the leg up, and the heel is laying off of the bed. Or you could sit the patient in a recliner and a chair in front of them and raise that leg up and let that heel float off of the edge of the chair. So we want to make sure either way, whatever technique you choose, that we are offloading the pressure and repositioning the patient from those high pressure areas. Because if the patient is in a nursing home, they are much more likely to develop a pressure ulcer on their sacrum or either heel. So now, in review, we only had three clear objectives, but those objectives had a lot of information that came with them. So, the first objective we had was to identify the role of the registered nurse in wound care. So, we talked about the importance of assessing the skin and making sure we document correctly everything we see. Now, in order for us to document correctly everything we see, we had to learn more about the distinct differences between the types of wounds. So, we talked about the types of wounds. Now, we also talked about the preventative techniques that we can use to prevent wounds from developing, and also techniques we can use to actually reduce the severity of a wound if it unfortunately has already presented. So, the role of the registered nurse, quite simple in wound care. I tried to break it down, something you guys can remember: assess, document, prevent, reduce. That is our role in wound care. But remember, as we talked about, I tried to make you guys understand that the nurse is responsible for all aspects of care in wound care. Now, don't forget that, guys. That's why I boxed it in on this slide here. The registered nurse is responsible for all aspects of wound care. Okay. Now let's get to our last slide. Um, so our second objective was identifying the major pressure points of the body susceptible to pressure sores. So slides 7, 8, and 9, we talked about, we had a lot of visuals, screens 7, 8, and 9. So we talked about where the wound is. The most common areas would be shoulder blades, buttocks, the sacrum. Um, Specifically, we talked about the spine, the soft tissues of the butt, the different positions and areas of high pressure to note. Um, we defined what a high pressure area is, and we even talked about high pressure areas related to medical devices and the more common medical devices that we need to look out for, which were nasal cannulas and Foley catheters, were the specific medical devices that we need to look out for in regards to patients developing a pressure sore related to simply the presence of a medical device, because our body, so behind the ear, specifically on nasal cannula and the thigh uh, in relation to a Foley catheter, our body is constantly in contact in these areas with this medical device. We want to make sure that we use something of a barrier in between them, or we're rotating the Foley catheter from the right leg to the left leg. We're uh, using some type of cotton or gauze wrapped or cloth wrapped around the gauze. I'm sorry, not the gauze, wrapping around the nasal cannula that goes behind the ear. This is just to break up the constant pressure. That is the root cause of these pressure sores, is the constant pressure against the soft or weakened skin in certain areas. And last but not least, our objective was to identify various wound types and a basic assessment findings. So slides 13 and 14 and slides 22, specifically, we talked about venous ulcers. We talked about their location. We talked about the size and shape and color. Um, and then we compared it to arterial ulcers. We talked about the location as well, the size, the shape, and the color. We talked specifically the location can be used and the size and shape. So remember, arterial ulcers, they appear to be more punched out and occur in the feet. And venous ulcers occur in the lower leg and they appear more irregular, large portions of the leg, and they're shallow. So, also slide 22. I just brought this up for comparison so you guys can see. Stage one, it's just a reddened area. Stage two, the wound has broken through the epidermis, may or may not have broken through the dermis. So you can see, remember this wavy line here is supposed to represent the dermis. Um, Stage three, the wound takes on the shape of a crater. The epidermis and the dermis, both layers have been broken through, and even some of the subcutaneous fat here. And stage three, don't forget we may or may not see pus from this area. Uh, Likely no pus, but most likely and definitely some pus here. So in stage four, it's broken through the epidermis, the dermis, the subcutaneous fat layer. You see this yellow layer here is completely gone, and it's exposing the bone here in this area. So that's the comparison, stage 1, 2, 3, 4. So we talked about all these things today, all this information about wound care. We checked off all of our objectives. I hope that you feel like more confident in your ability and skill and understanding of not only your role in wound care management, but the steps we can take or you can take to improve your skill and care for your patient who may be more susceptible to developing a pressure sore or may have unfortunately already developed a pressure sore. I want to thank you for your time today with me. And again, my name is Deontay J. Marquis. I'm a family nurse practitioner with over 8 years of experience, have a registered nurse, and I am presenting to you on behalf of my ALF training. I hope that I see you again and have a good day. Thank you.